So you guys are able to see my screen, right?
Yes, your screen is visible to us, and that is also changing. You can make some changes. Okay, sir, can we start on your permission? Okay, very good evening to all of one. First of all, I welcome Dr. Manik Chabra, uh, as he was our good student, and really thank to Dr. Manik Chabra has given time, and I want to give thanks to our worthy principal sir, director cum principal sir, Dr. G.D. Gupta sir, thankful Dr. Saurav Gupta sir, head of department pharmacy practice, to be give such a chance organizing such alumni talk series that we can contact our old students. They can guide us for our, in the knowledge sense of knowledge, in the sense of our placements, and so much ways they can guide us to our students. I want to share the one some about Dr. Manik Chabra. Dr. Manik Chabra is a PharmD alumni of ISF College of Pharmacy, Moga. He did his PhD in pharmacology and therapeutics from Max Reddy College of Medicine, University of Manitoba, Winnipeg, Canada. Dr. Chabra is an accomplished researcher whose expertise lies in medication safety among vulnerable populations, population-based studies, evidence synthesis, and clinical trial methodologies in vulnerable populations, including children and patients with low kidney function. Across his academic and professional journey, Dr. Chabra has had various roles. He worked as a research assistant with the Department of Pharmacy Practice, Naipur Mohali, the Child Health Research Institute of Manitoba, and the Clinical Pharmacology Lab at the University of Manitoba. He also served as a research data analyst second with the kidney dialysis and transplant research team at London Health Science Centre, and is currently a postdoctoral associate with ICES and the Department of Epidemiology and Biostatistics, Western University, London, Ontario. He has published papers in prestigious journals like JAMA Pediatrics with an impact factor more than 25 and Nature Scientific. He is his scholarly contributions have been widely recognized. Over 900 citations, H-index 18 and I-index 28. He is an active member of the International Society of Pharmacoeconomics and Outcome Research and the International Society for Pharmacoepidemiology. He is also the founder, president of the ISPAR student chapter ISFCP. Among numerous accolades, he has been honored with the Dr. Mark Nickerson Entrance Award in Pharmacology and Therapeutics, the Shiv Lee Family Scholarship in Oncology, the FGS Research Completion Award, the Research Manitoba Doctoral Fellowship Award, the Western Postdoctoral Fellowship Award, and the Best Poster Presentation Awards. I really welcome you, Dr. Manik, to have with us, stay with us, and given time in a very short notice, and really thankful. And it's the stage I want to give to you to start your lectures, because we are eagerly waiting what you the good things brings for us. So our students are very eagerly waiting. Please, over to you, Dr. Mani.
So thank you very much, Dr. Madhav Dwivedi sir and Dr. Saurabh Kose sir for giving me this opportunity for sharing some knowledge with you guys. So before I begin, I would like to thank all the audience for joining for this session. So before I begin, the title for my talk is Principles of Pharmacoepidemiology and Drug Safety for Beginners, especially one who just want to just start what pharmacoepidemiology is and what are different things you need to consider before designing any drug safety studies. So before we begin, so you guys might be wondering, what is pharmacoepidemiology? So pharmacoepidemiology is study of drug utilization, then its influence on health outcomes, and then with principles of epidemiology, we bridge all together to study real world risk and benefits of medications. Then now you guys might be wondering, why pharmacoepi? So before we begin, if we see clinical trials, they have very strict inclusion and exclusion criteria. So possibly they exclude patients who are really sick, or they exclude patients who are vulnerable to adverse events, like patients, especially if you guys are designing your fifth year protocols. So you must be writing, oh, we are excluding patients who are breastfeeding or pregnant moms, and that's a, again, drugs are to be used in those population too, and then clinical trials do not really present the real world population. And if we see in population in real world, we have different age groups. If we just talk about children have sub age population, like we have infants, neonates, toddlers, adolescents, and youth. And while we have pregnant, breastfeeding moms, we have geriatric patients, and then patients with comorbidities, like someone with low kidney function, someone with hepatic failure, low hepatic functions. So clinical trials do not really mimic the real world scenarios, and that's the reason we need to study drug safety in real world, so that it can be further used to inform clinical practice and policy. So that's the reason why we need this pharmacoepidemiology and drug safety. And just to summarize, before we begin, about study designs, which I'll be talking in my coming slides, for a layperson or just a new beginner, if you just want to do any, if you want to take out any study, or you want to plan and execute any studies, first of all you need to focus on your study design. You need to select appropriate study design based on your appropriate research question. And then further, once you have selected appropriate study design, which is further followed by authentic data collection by any mode of mean, whether if you are doing any systematic literature review, you will merge, or you will leverage into different healthcare databases, and then you will select particular studies. Or if you are doing real world drug utilization review, you will go and you will look into health records. And if you're doing any sort of cohort studies, either you will do any sort of data collection, or you can leverage into administrative health records. Then further, which is the collected data is followed by data analysis, which is done with different statistical packages or statistical softwares like SAS, R, SPSS, and even if someone who is very expert in Excel, they can do so those same things in Excel. Then you write report and then you publish it. So now let's talk about study designs. If we see, I'll just, so these are the stairs. So stair one is editorial and expert opinions. For editorial and expert opinion is, this is something I got an idea in my mind. Okay, people who are eating different types of food, are there any risk of diabetes or something? So I'll just have an expert opinion, I'll write letter to editor, and I'll submit that to journal. And then once that letter to editor comes out, and then people think, oh, maybe this is an area where we can conduct cross-sectional survey, and we can look out how many people are exactly using this particular intervention or particular behavioral therapy. Then later on, you found out, okay, some people who were using drug A, B, C, and then they were having like good outcomes. You plan to take out those case and you publish as a case report. And then later on, if you see consecutive cases, you go for case series. And I'll touch base on each study design in my coming slides. Then later on, you just compare them with different groups, people who use that particular drug and people who do not use that particular drug. And then you just do a case control study, and then further cohort study. And then later on, your funding agency gives you millions of dollars, and then with that money you can conduct randomized controlled trials and evaluate the safety and efficacy of intervention in the real world. And then ultimately, as you climb the ladder, then comes systematic literature reviews and meta-analysis, where you just bring down all the similar type of studies, you pull them, and then you say, okay, we have done systematic literature review, which further informs clinical practice guidelines, clinical practice, and sometimes they also informs policy. So now let's begin. What are case reports? So case report is a detailed report of symptoms, signs, diagnosis, treatment, and follow-up of an individual patient. And case reports are for single patient. And what are key sections of case reports? Like you will write patient description, proper case history, physical examination results, which includes like you usually physicians do the some physical examinations like blood pressure, heart rate, or any other physical signs, then result of any pathological tests or any other investigations, which include CBC and other examinations, then what treatment plan patient was given, and then expected outcome for that treatment plan, and then later on which is ended by actual outcome. So this is how like a typical case report looks like. And now you guys must be wondering, okay, uh, I'm talking about pharmacotherapy and drug safety. So I'll just tell you how typical case report related to adverse event response to therapy looks like. Like you will have a case history, proper medical history section, where you will have, okay, what kind of comorbidities patient had before, then medication history, what kind of medications patient was taking. Then you will look for temporal relationship, when patient took that medication and he developed certain adverse event, and what was the time gap or time difference between taking that medication and developing that adverse event. Then causality assessment, which you guys must have covered in your clinical pharmacy. Like we have different causality assessment scales where we just see causal relation. Causal means cause, how you are just determining whether that adverse event is really associated with that particular drug, that particular drug is associated with that adverse event. And then later on, drug D challenge, where patient was taking drug, and then you took off patient from that drug and those signs and symptoms disappeared. So we call it as drug D challenge, and sometimes called drug re-challenge, where patient was taking drug was taken out, patient symptoms subsided, and again drug was reintroduced, and that leads to re-challenging, like kind of reappearance of sign and symptoms. And in such cases, like this is not ethical to do, but though in cases patients who are suffering from HIV, tuberculosis, in such scenarios, physicians go for this re-challenging. And then severity of adverse events, drug reaction. So this is usually done using different severity assessment scales which are available in the market. And now I'll talk about case series. Now, case series, if you see you are having now multiple case reports which describes of single patient, and now you are clubbing all of them together, and then say like it describes group of patients with particular condition or exposure. So exposure can be drug, whether specific class of drug, providing detailed information about their characteristics, outcomes, and follow up. Then you need to have specific inclusion criteria. Okay, what was your criteria that you are considering those patients? Okay, patients with so and so age group, taking so and so drug, with so and so a drug dose range, and so comorbidity. So there should be strict inclusion criteria all for case reports. And this is usually, if you publish your case series without this, so your case report may get scrutinized by different critical appraisal tools like JBI and NH. Then later on, a precise operational definition of case is crucial for reliability of study. And then there are different sampling techniques for case series, either based on disease or exposure or based on specific outcomes. So this is all about case series, and I'll just stop in between if I'm going too fast. So are there any questions so far? Feel free to unmute yourself and pop in the chat, or anybody can narrate question to me. I'll give a 20-second pause. So I'm hearing none. Well, I'll proceed further. Then in case series, you select variables of interest, like specific outcomes you want to see, detailed section, and clear definition of predictive variables of interest, like what kind of predicted variables. Okay, someone is checking effect of drug A on outcome XYZ. So you are just checking out whether are there any predictive variables like patient is alcoholic, patient is having any history of smoking or any specific comorbidity, and then specific test results like if you want to evaluate effect of some drug on fractures, you just want to see what was the uh, bone mineral density, and then you will see calcium levels, vitamin D levels, then specific intervention. It can be either drug or any medical device, then complications, and then specific adverse events which you're looking, and outcomes. If you are evaluating diabetes, there are core set of outcomes tools available in the market. And then for diabetes, like you want to see baseline and follow up, mean reduction in HbA1c levels or any blood glucose levels, the kind of outcomes you need to select. Then systemic collection of data, robust analysis as they assure the quality of case series study. And now this is one example. Okay, see, there was a drug which was leading to Parkinsonism, and someone during their clinical practice they found drug XYZ is causing Parkinsonism, and they define their inclusion criteria, and they collected all the case reports of that specific patients, and then they publish as a case series, and that they publish in Journal of Medical Case Reports. This is the way you can publish case reports of drug safety. And then cross-sectional studies. So cross-sectional studies are type of studies which collect data from population at single point in a time over very short period. So you are a class of 30 students, like PharmD we usually have 30 people. So you want to see how many are obese. You will just go and collect data, and you will see, okay, that on year one, when students started their PharmD class, and on first month you found like five kids, five students were obese, 5 out of 30. You will find like prevalence of people who are already obese. And then later on, if you want to conduct cohort study or cross section study, cohort study or case control study, you will follow up them like from first year to year 5 and see how many were obese on day 1 and how many were obese when they finish their PharmD. So these kind of things you can use just as a parameter to calculate various effect estimates. So I was talking about prevalence. So what prevalence is? So if you see, prevalence is a proportion of individuals in a population who have specific characteristics or conditions at particular point in a time over specific period. As I told you, you have 30 students, out of 35 are obese. So your prevalence would be like calculated using a formula. So total population or a specific subgroup divided by number of existing cases. So if a health survey finds that 15% of population has diabetes, and prevalence of diabetes in that population would be 15%, meaning 15 out of every 100 individuals have diabetes at the time of survey. So cross-sectional studies are just telling you how many patients had that specific outcome when they were surveyed or when they were interviewed, and they're not telling any causal relationship. Okay, this specific, like if I say 5 students were there in PharmD and they were like obese on year 1, that doesn't mean that they were obese and they took PharmD. That's not specific relation path. Then there are certain limitations. So if you see temporal relationship, since data is collected at single point, establishing a cause and effect relationship or determining the temporal sequence of events can be challenging, and it is impossible. So there is difference between prevalence and incidence. And if you see, cross-section studies provide only prevalence data, do not provide anything on incidence. Incidence is number of new cases and prevalence is number of existing cases. And then if we see kind of pharmacovigilance things you guys are doing, if I know you guys have a pharmacovigilance center where you collect spontaneous reports. Again, those things are type of cross-sectional studies, and spontaneous report of adverse events refers to dissemination of information, findings from volunteer submission of adverse event reports related to drug use. And this also falls under pharmacoepidemiology and drug safety. That's why I'm covering. And then these reports are either contributed by healthcare professionals, patients, or consumers, and are typically compiled and published in various forms, as in the scientific journals, pharmacovigilance databases, or regulatory reports. And even if you get something, you just find a trend. Okay, this specific adverse events are commonly reported, or any specific adverse event is reported rarely. You can publish as a case report, or you can bunch them together, have a inclusion criteria, and publish them as a case series. This is second thing. And third thing is you can publish all of them together just to see the pattern of adverse events in the Moga district, and then you can publish as a spontaneous report in it is accepted by various journals. Then goal of publication, again, why we are sharing this publication, just to share real world data on drug safety, identify potential signals. And if you see in under pharmacovigilance program of India, they do submit signals, and they say, okay, this drug is specifically associated with this outcome, and they do signal analysis using proportional reporting and ROR. That's again different kind of stuff which we call it as disproportionality analysis. And then those signals are conveyed to healthcare professionals, and then healthcare professionals are further informed to be very vigilant, to be very cognizant while they are monitoring their patients on those specific drugs. And then these publications play an important role in medical scientific communities, informing emerging safety concerns, especially with those medications in the post-marketing settings. As I told you, once drug receives regulatory approval based on their clinical trial data, but in real world, there are still like the drug should be scrutinized for safety, and there should be some mechanism for which we should evaluate its safety in the real world. That's why we do pharmacotherapy and drug safety kind of stuff. Then later on, if you see now you guys are standing, and like for today, if you're standing, this is present, the middle line. And if you want to look something back date in the past, we call them as like retrospective. And then if you want to look something in future, we call it as prospective. And these are certain type of designs. So now here, exposure can be anything, can be either drug, medical device, or any sort of intervention. And then you are now I'm talking about case control design, where you just see exposure, outcome, and now you're doing from present, you're going from outcome to exposure in case control studies. You're selecting patients with outcome as cases and patients without outcome as control. And then in from now you're going from present to future, you'll call it as like prospective case control study. And then if you're going from present to past, you will call it as prospective retrospective case control study. And then if you see cross-sectional studies, where in cross-sectional study, I'm just summarizing what I told you just right now. In cross-sectional studies, individuals are examined at single time point from which we derive incidence, prevalence of that specific disease condition or any factor. And in case control studies, we have individuals with particular outcome, and then we look out for different factors. If they are present, then okay, or if they are absent, then same thing, individuals without particular outcome, and then we see whether factors are present or absent. This is how we evaluate case control studies. And in core studies, we selectively select individuals exposed to particular factor and then presence of that outcome. And then in cohort studies we even look individuals without exposure and then that specific factor. But main thing is we need to be very cautious that both the groups are comparable. For example, someone wants to study the effect of recently, like there is one drug, we call it as GLP-1 analogs. They are very famous in the market and people are taking it for their obesity. You want to see person cardiovascular safety of GLP-1 analogs, and you are comparing GLP-1 analogs in patients who are obese versus safety of GLP-1 analogs in healthy individuals. So, do you think that is like kind of apple to apple comparison? Anybody would like to unmute yourself and participate? Anyone?
One thing, Manik.
Yes, sir.
Hello. You just clear prospective and retrospective cohort, because the
Yes,
and
sir.
prospective and retrospective cohort with any example, it will be beneficial for our students
Yes,
if
yes, sir,
possible.
for sure.
If
For
possible.
sure. I have examples coming up for that. uh, I have examples with numbers like where they can do calculations if someone is really interested to participate. Thank you, sir, for bringing this up. So, anybody else want to tell? Like we're comparing GLP-1 analogs for their cardiovascular safety in patients with obese versus patients who are healthy. So I'm hearing none. So do you guys think if I just compare normally, they say, oh, their son is doing really good. He's doing this, he's doing that. But again, they're comparing you with someone else who has different type of resources. But again, I feel that is not like right comparison. You are comparing apples with oranges. In reality, if you want to compare something, you should compare apples with apples of same size. So one side you are taking obese individuals, other side you are taking someone who is healthy. So person who is healthy will have less incidence of cardiovascular events compared to person who is obese. He will have higher triglycerides. He may have other comorbidities. So he may likely to get more incidence of MI or any fatal cardiovascular incidents. So in that case, this is the main thing. Whenever you're designing any study, you have to compare apples with apples. So next thing is case control study. So this is something, right now you have a population, and this is like main source population, people who are living in, I will say, Moga district. And then from this population you select cases with outcome. This is again, I'm talking about retrospective design. You are now selecting cases with outcome. Then later on, from that same source population, you are now selecting controls with outcome, and then you go back and just see what factors they were exposed. Usually this is done using administrative healthcare records, or you can even review patients files, patient charts, but there's some sort of biases in that. Sometimes if you're doing interviews, someone who developed cardiovascular accident and he was on drug rosiglitazone, I can say PPR gamma analogs, and then you say, okay, was that due to that drug? And you will say, can you remember you were taking this drug and you developed this incidence? Like what sort of other drugs you were taking in over span of 5 years? So there comes patient is not able to recall what exactly she took. We call it recall bias, but still we'll come back to our topic. So now in this case, what will happen is, based upon certain factors, you will classify patients in exposed group and patients who are in non-exposed group. Then same thing will go with controls. You will see patients who do not develop outcome, but how many had that factor and how many didn't have factor. And this particular design is retrospective design, where you have outcome in your hand, and then you are assessing how many were exposed in now who developed outcome, and how many were non-exposed. And same thing you will do in your control group. You will see how many were exposed and how many were non-exposed. So any doubts so far? And this arrow indicates your query, and this is typical retrospective design. Any
Yes, this
doubts,
is
any
very good
questions?
explanation. Yes, this is very good explanation, this case control study, and really it is very good.
And we are going from present to past. And then for this study, the design I would call as typically a retrospective case control study. Now let's move on to next, like what are different strengths for case control studies. We have very fewer ethical concerns. For example, I want to study effect of smoking and lung cancer and patients who develop lung cancer. Now here is a scenario: patient who develop lung cancer, and I want to see how many were smokers and how many were non-smokers. Then I'll select another control group from that same population who do not have lung cancer, and then I'll see how many were smokers and how many were non-smokers. Based on that, I can do that. But if I want to do randomized trials, and I'll say Dr. Sorokose sir, he got $1 million grant and he wants to see whether people who are smoking are they really developing lung cancer using randomized trials. He cannot assign that ethically. We will not get ethical approval for that. So in such cases, when things are unethical to do, but still that thing prevails in our society, we go for case control design. And then this is more efficient than cohort studies, then requires less time and money. If you want to do a randomized trial, you need a lot of money and a lot of resources, and this is very less time consuming and less money. Fewer subjects needed to measure an association, and this is especially helpful when exposure information is expensive to obtain. Then no need to wait for long latency diseases to develop. So if we see something has very acute window, like latent period is very short. So you guys now might be wondering what is latent period. For example, I took drug A, and Dr. Madhav sir, he took drug B, and then I want to compare effect of drug A versus drug B, but there is time where effect of drug A will kick in. So I'm taking drug for 10 days, 20 days, 30 days, and I'm evaluating effect of some cutaneous adverse drug reaction. So there will be a time between taking the drug and then onset of action, when that action will start coming up. So that time period is like we call it latent period. And if that latent period is small, case control study is like good. And if it is long latent period, you need to go for cohort design, which I'll talk about in coming slides. And then this is useful for diseases with little information or unexplored etiology, something which happened during COVID-19. People conducted a lot of case control studies, like patients with COVID and without COVID, and then looked into different factors. What are different factors which can be associated? Or you can even go for infectious breakdown. There is some rotavirus breakdown in Moga, and then you are comparing different factors, people with rotavirus, without rotavirus, and what are different factors, people who are exposed and people who are not exposed. Then limitation. So everything comes with a limitation. So there is limited to studying single outcome, not good for rare exposures, risk of systemic bias, recall bias, and selection bias. So you won't be able to recall. If I say person XYZ from you, he took drug 5 years back, will he be able to recall? No. So that's kind of bias. And maybe unsure about time sequence between exposure and disease. You are not sure something which is very new. You are not sure what is latent period of that specific disease. So this happens during that time. And then there are different measures how you can calculate different risks and odds ratio, which I'll touch now in this coming slides. So what is relative risk? It's a ratio of a risk of event in one group to risk in another group. So I'm comparing risk of, if so now you have, I told like someone who took admission in PharmD first year, and then we followed up that person for 5 years, and then I'm following one cohort of PharmD students from first year till year five, and then I'm following cohort of BPharm students from 1 year to year four. So I'll make PharmD first year to year four for PharmD, and then same year one to year four for BPharm, and I'll compare the risk of obesity in PharmD students versus risk of obesity in BPharm students. So once I get that risk ratio, I'll come up with a ratio, and I'll say, okay, PharmD students are 2 times less risk of getting obese as compared to BPharm students. Then next thing we talk in pharmacoepi is odds ratio. Odds ratio is ratio of odds of an event of developing any disease in one group to odds in another group, commonly used in case control studies. So odds ratio is odds of exposure in control versus odds of exposure in cases. So now let's talk about this risk ratio. So this is an hypothetical example. We have a data on 60, I would say like 60 lakh people in source population, 60, 100,000, and we compute the probability of a disease for risk or incidence in both exposure and non-exposure group. Anybody would like to solve this equation? Can you calculate risk ratio for this? First, you have to calculate risk in exposed, risk in non-exposed, and then divided by ratios. Anybody would like to volunteer? So I'm hearing none. So if we see risk ratio in exposed, I have patients with outcomes. There are 700. 700 divided by total population, which is 1000. Then I have non-exposed. If you see on the this, even before this, I'll just tell you what this table is known as. We call this table as contingency table, where we have two by two table, where you have exposure, and then with the responses, two responses, yes exposed or not exposed, then outcome columns. Then in outcome we have yes outcome, presence of outcome, or absence of outcome, and then we have sum up things. So in risk ratio we have like this 700 patients with outcome divided by total population. Just example, this is example like patients who are in PharmD, they were like one with three six zeros, and then another was like 1 million population, and then 600 out of 5 million, those they develop the outcome. So you are calculating their ratios, then ultimately you are dividing them, and then it comes like 5.83. So here I develop, and this is effect estimate. We don't calculate confidence intervals with that. That is again for intermediate stuff. For beginners, I would say. So patients who are in exposed group, they are almost 5.8 times likely to develop that specific event compared with their respective non-exposed group. And so if you want to calculate risk ratio, the pattern is same whether it's a case control study or cohort study. So now I'll talk about cohort studies. In cohort studies, you will have exposed group, and then on the other side you will have a respective unexposed group, and make sure that exposed group is similar to unexposed group, and then you follow up those patients to whether they are developing that outcome. Then you will categorize those patients with outcome, without outcome, and same goes with unexposed group. You will follow up them, and then you will see whether they develop outcome or not outcome. And you are now structuring your query from present to past, a present to future. So this is this particular design, I would say, I will call this as prospective cohort study. Then now if you see, now I was talking about lung cancer and smoking. So this is odds ratio for this. Like, if what are odds of having history of smoking among those who are lung cancer is equal to history of smoking with lung cancer divided by no history of smoking with lung cancer. So this is 48. divided by 2, and then this is something I am calculating. Then later on, what are odds of having history of smoking among those without lung cancer is equal to history of smoking without lung cancer divided by no history of smoking without lung cancer. So it is 250 by 750. And now my odds ratio is coming. Now I'm dividing 48 by 2 into by 250 by 750, and now odd is coming 72. So there is like, now I will interpret this like there are 72 odds of developing lung cancer with smoking. And then now strengths cohort studies help to study multiple outcomes in same exposure. And if exposure is rare, then cohort design is very efficient method to study the relation between exposure and outcome. And now you see retrospective cohort study, something which is done from present to past, can be completed very fast and relatively inexpensive compared with prospective cohort study, which is done from present to future. So you need less resources, less money for that. And then since at the time of entry into cohort, individuals do not have outcome, the temporality, the time is the relation right now over here, which we were not able to establish using cross-sectional designs, which I covered few minutes back. So you can have a temporal relationship and find out exactly what is incidence of that specific outcome in that specific population. Now let's talk about limitations. So one major limitation of prospective cohort study is that it is time consuming and costly. For prospective cohort, I'm telling, not for retrospective. Example, if you have study of incidence of cardiovascular patients, incidence of cardiovascular disease in patients with psoriasis, you may have to follow up them for years. And if you're following up them for years, you need a lot of money, lot of time, lot of resources. And in retrospective study, the exposure outcome variables are collected before the study is initiated. Thus, measurement may not be accurate or according to our requirements. In addition, some of the exposures may have been assessed differently for various members of the cohort. For example, I just want to study the effect of smoking. For someone will say, I smoke 2 cigarettes. Someone will say, I smoke 3 cigarettes. And someone says, I just smoke one puff. When one puff, how much carcinogenic agents are going in is totally different compared to three different. So it is difficult to quantify the exposure. So in such cases, you need to be very cautious when you're doing cohort study. So exposure should be well defined. Then at last we have randomized trials. They are type of experimental studies used in clinical research to assess effectiveness of interventions or treatments. And if the randomized trials, they are considered gold standard. Now, if I was in person, I would like to hear from you guys. Why randomized trials are known as gold standards? Anyone? So, hearing none. So, randomized trials, they are
Sir,
very good.
in randomized control trial, mainly we find out the new treatment versus placebo.
Yes,
Yes, sir. We compare the how new drugs are effective against the standard or placebo drugs. That wise we call the gold standard uh, control
yes,
trial. Yes, sir.
yes. Yeah. Thank you for participating in the discussion. I appreciate. So, that's a good response. And here are some features what makes randomized trials as a gold standard. Like, we have randomization is kind of, they randomly allocate subjects between, as someone said, we compare effect between intervention and control group, between placebo and intervention group. So we randomly allocate. So if we are doing random allocation, you will be uniformly distributing participants across different groups. So like, I'll just give you lay example. So you guys are like class of 30 students and you want to play basketball, and then I choose two different captains, captain A and captain B. So initially what will happen, like if I give choice to both of them, they will initially they will choose all the good players at once, and then we will have 15 players which are left, okay, they are not good, and one team will have very good players, another team will have bad players. So same case goes with the patients. Like some patients are with comorbidities, some patients are with different smoking, alcohol habits. They can affect the outcomes. So we use process of randomization. So then what I will do is I'll say captain one, okay, we can flip a coin where I'll randomly allocate. Okay, if it is like head, pay, that participant, this participant will go to your group. If there is tail, that participant will go to another group. So there is 50-50% of probability that good player can go to team A or team B. So this way you are making both the groups look same, like you're comparing apples with apples. You're not comparing apples with oranges. Or someone say, they say like, oh, Sharma ji ka beta is doing very good, but that doesn't mean like you are built like Sharma ji's ka beta. So this is like you're comparing same look alike groups. Then it has control group. Then we have blinding, which helps in prevention of detection bias, especially if you see you are in a clinic and very busy clinic, and if doctor or nurse knows that this patient will get drug, another patient will get placebo, they'll say, okay, oh, this patient will outperform the placebo, so we will give him very good rating on outcome assessment tools. So we call this, that's why we do blinding, so that we can prevent detection bias, which is like based on nurses practitioners. And sometimes patient will know, okay, oh, I'm getting this specific drug, I will have more or less kind of side effects or less pain. So that's why we have blinding. Then outcome measures, we have power calculation, then random allocation concealment. Nobody knows who is receiving what, and then they even conceal that. So these are the key features which makes randomized trials as the gold standard. Now, next thing is systematic literature review. So, if you see, systematic review is a comprehensive and structured synthesis of existing evidence on specific research question or topic. So now you are a person. So there is outbreak of, like now we had floods recently. We had floods in Punjab, and there were outbreaks of infections. So you want to see, okay, which drug should be given as a prophylaxis so that nobody catches a disease in Punjab. So what you gonna do? You will do is, what you will do is you will select all the studies which are published in the patients who suffered from disease, or what, or all the drugs which were given as a prophylaxis for floods. And then you will see, okay, with which drug less number of patients suffer from disease or any comorbid condition, or patients quality of life was improved. And then later on you will synthesize all the findings and you will give recommendations. You will say drug XYZ should be given to the patients if you really want something good for the people of Punjab or people of that specific region. And then primary goal of systematic review is, again, it is it provides unbiased, transparent summary of evidence so that it can inform decision making in healthcare. uh, Now you someone is very busy practitioner. My friend is a neurologist, so he has like 5-6 antiplatelet drugs available in the market, and he asked me, okay, can I give aspirin, clopidogrel, ticlopidine, or drug XYZ to patients who are suffering from transient ischemic attack? And I'm like, oh man, I this is for someone's life. I need to see which drug has less side effects and which drug is more efficacious. I will systematically look into the evidence, and I'll say, okay, as with aspirin, there is less recurrent strokes. Then, based on my systematic review, I am providing very unbiased and transparent summary of available evidence, and that informs either clinical practice and policy, which I just mentioned, drug for floods areas or any other field. And there are certain strengths for systematic reviews. They are very comprehensive. They synthesize all evidence on topic, transparent. You are registering your protocols prior to conducting your systematic reviews, and you are following Prisma guidelines for this, and then there is very less chances of minimized bias. We have very robust methods like structured search, study selection, data extraction process, then evidence integration to combine findings from diverse study designs, then identify, and they help to identify research gaps. What are different indications where that drug hasn't been studied that can be used by pharmaceutical industry to further inform their research and to launch their drug in that particular geographical location, and then can be used for sport decision making or through for quantitative synthesis, which we call as meta-analysis. So now I have exercise for you guys. Suppose we follow 1,000 patients for 1 year, and by end of year 50 develop diabetes. So what measure you would calculate to describe the risk? Anybody? I'll repeat the question. You guys can think, and I would love to hear from you. Suppose we follow 1,000 patients for 1 year, and by end of the year, 50 develop diabetes. So, what measure would you calculate to describe the risk? Anybody? There is no wrong and right answer, and don't feel yourself offended. Please unmute yourself and speak.
Sonu Kumar, give answer. Ravi
Sir,
Ranjan.
due to network reason, I don't hear the question. Please repeat, sir.
So,
Sir,
question is, yeah, go ahead.
sir,
Sir,
mainly I may 1,000 patient for only follow the patient for 1 year. We find out that it is a type of cohort study.
Mm-hmm. Good.
Yes, sir. Sir, mainly we find out the calculated relative risk we can calculate from this, or
Yes.
yes, sir.
Yeah.
My
Yeah.
yeah,
That's good. This is something I'm satisfied with your response, and I'm okay. At least I made a change. So I'm happy by spending like 2 3 hours preparing these slides. So I'll just tell you, we will calculate cumulative incidence, which you just told me. I'll
yes,
calculate as 50 divided by 1,000, which is 5% in 1 year.
yes, sir.
And now another scenario. Now I have follow up time ways. If you see here, I was telling I'm following up 1,000 patients. Do you think in reality are you able to follow up 1,000 patients from end to start in real world? Like I'm just telling, okay, do you think we can follow up these patients? Like there are chances that patients, someone may die, someone may go to some other country, or someone may migrate to some another state. This is like real world scenario, like people come and go. We call this like population is like very very dynamic, like it changes every interval. For example, when you started PharmD, how many students were there during your year one? There were 30, right? And when you are finishing up, anybody can tell how many students you have in year 5 now? Somebody left, or somebody got into another college, or somebody fly to Canada, which is a trend in Punjab, right?
Yes, sir.
Yeah. So now you imagine, imagine not everyone is followed for full year. Some drop out after 6 months, and some stay longer, or like you guys, some stay stronger for year 6 for family. Then you may, what mayor would you use now? Any idea? This is something new. So we calculate person time incidence in such cases. If I was supposed to calculate that, if you see it was 5%, if I'm following that 1,000, I'm calculating that based on patients, how much I followed. And if I'm calculating this, I lost 200 patients, and now I have 80 patients, and now my risk is like incidence. I would say this like uh, this is 6.25, which is like higher than this one. So we need to consider this person time incidence while we are calculating this. So Here is something we call it cumulative incidence, proportion of population that develop outcome during a fixed time period, which is we use this formula to calculate it. Cumulative incidence, number of new cases divided by population at risk at start. So in cohort of 1,000 patients, 50 develop diabetes. We'll say 50 by 100, 5% in a year. Then later on, see, this is rate of new cases per unit of person time at risk accounts for varying follow-up times. So incident rate is equal to new cases divided by total person time at risk. So 1,000 patients were followed up. Total follow-up was 60% years. 50 dual diabetes. So incident rate is 50 divided by 800. So though you are seeing this 5% and 6.25, there is huge difference. Like there is difference of 1%, but that matters a lot, especially when you are designing clinical practice guidelines. So I won't go more deep. So there are some certain biases in pharmacoepi, which Dr. Madhav sir told me to cover so that you guys can use while designing your PharmD fifth year projects. So if we see confounding bias occurs when exposure and outcomes are both related to third factor. So this is very common in observation studies. Example, disease severity influencing drug choice and outcome. So if you see insulin, you want to just see effect of insulin use in patients with diabetes, and someone who is using insulin, he may be on a worse disease condition. You're comparing now insulin users with oral hypoglycemic users. Now patients who are using oral anti-hyperglycemic agents must be just someone who is newly diagnosed, who are with controlled blood sugar levels. But someone who is using insulin, their blood glucose levels are not controlled. They are having more disease severity. This is like typical example. If you see, you cannot compare oral hypoglycemic agents with insulin users. So if you want to compare insulin users, should be with insulin users only. The patients whom you are comparing should have equal disease severity. Otherwise, your outcomes may get confounded. So this is what typical term we use in pharmacoepi. The results are confounded. So another example, patients on statin appears to have low mortality. Someone is taking statins and they have low death rate. You know reason why? Someone is taking statin, doctor told that person, take this statin, your heart attack risk will reduce. So that patient is like, now, oh man, I am at risk of heart attack. So he will start exercising, he'll start eating diets, salads, and that person will be likely to live more. And this particular thing makes confounding. So whenever you're comparing someone taking statins with another statin, you need to make sure that patients, there should be equal number of patients in cohort who are taking statins, who are exercising, versus patients in control group who are taking drug XYZ. Should have equal number of patients who are exercising. Otherwise, you will have confounded results. And then if you see confounding by indication, this is another thing. So you just took out some data and you found out patients who were taking paracetamols and there was fever as a comorbidity in them. Patient, but that is confounding by indication. Patient got fever, that's why patient is taking paracetamol. It is not that paracetamol is causing fever. And if you look into FIES database with anti-epileptic drugs, there people have reported seizures, but that is not something. Seizures are caused by anti-epileptic drugs, but patients are taking anti-epileptic drugs for seizures. This is something you need to classify while considering your pharmacoepidemiological drug safety studies. Now comes selection bias. So this is again, you are selecting someone who is very healthy, comparing with healthy users. That is selection bias. Or we have another thing is depletion of susceptibles. Depletion of susceptibles means people who are coming to one clinic and they are having like mental health disorder and they are getting panic attacks, and you're comparing prevalence of panic attacks who are coming to clinic A versus prevalence of panic attack who are taking drug A and versus drug B in that same clinic. And then patients who are having more panic attacks, they will never come back to that same clinic, and you will lose those patients. That leads to depletion of susceptibles. You will lose patients who will get that outcome. They may go to DMC or some higher tertiary care teaching hospital for better patient care. Or sometimes you may lose patients. For example, you lost patients in an antihypertensive studies are often those with poor adherence and worse outcomes. As I told, like patients will not come to that hospital if their BP is not controlled, or someone who is not taking drug properly. Then we have information bias. So in your pharmaceutical labs, you do calibrations, right? So someone is measuring weight on scale. You're doing a multi-centric study in Moga and Dehradun and Delhi. Then your instrument should be same. It should look like similar, same brand, same calibration, same standard operating procedures. Otherwise, this can misclassify exposure or outcome. Even if you're evaluating drug, it should be of same brand. Otherwise, some drugs have low bioavailability, some drugs have less bioavailability, and then you can misclassify exposure. And always, this is another thing, that doesn't mean if doctor has prescribed the drug, patients are actually taking those medications. Some patients just they take the drug and then they throw it away, and you cannot assess. That study would be confounded. We call it as information bias, or there is wrong outcome coding error. For example, using prescription claims to define drug exposures, patients may never actually fill or take the medication doctor prescribed, but who knows that patient hasn't even went to pharmacy to take that drug. So you need to be very careful while designing your studies. Now, channeling bias. Certain drugs prescribed to specific patients, example patients who are sicker or healthier. Here is example like new biologics, which are very expensive. They are preferably prescribed to patients with severe rheumatoid arthritis. And now you're comparing those drugs with patients who are suffering from disease XYZ, that same rheumatoid arthritis, I would say, and you're comparing with normal beginner drug like first line therapy. So patients so that means you're not comparing apples with apples. And then another example is immortal time bias. So period during follow-up when outcome cannot occur is incorrectly attributed to treatment group. So you have assigned certain treatment to certain group, and then you are considering that lag phase also to calculate that person time, which I just mentioned in my previous slides. So you will have more persons followed up, and that you are considering that immortal time while calculating your effect estimates, while calculating your relative risk or odds ratio. So here is another example. In a cohort study of hormonal replacement therapy and survival, patient must survive long enough to receive the prescription, creating an immortal period that falsely favors treatment. So with this, I would like to thank you all for attending today's session, and I'm now open to questions. I would be very happy to answer your questions.
Very thank you. And we have some interested students. I am watching, and we have 13 students. Any questions from student side? So
Nice talk, Dr. Manik Chawla. And you told about all the aspects as I was watching all the slides. And this is a real-time focus interest. And you covered all the major research areas of pharmacoeconomics. And in India now, the trend has been started like decision tree analysis, SLRs, MS. So, and the various initiative by DHRs has been taken to establish the centers for evidence-based medicines. So this is one of the tasks which will be giving very much benefit to us all to write white paper on pharmacoeconomics. As Kalam Institute, Health Institute of India is taking initiative to write white paper on the pharmacoeconomics. and our sport chapter is working in same direction. So this talk is very beneficial in that context. Particularly, you have highlighted all the aspects. As I can see, no questions are there in the chat box. So literally, you have covered all the prospects, and I was listening and noting down all the things. Like nowadays, it is very much requirement for pharmacy and pharmacy practice concerns to cover this all domains which you have discussed. And one thing particularly I was very impressed about the talk was concerned about the future trends. As you see the prediction of pandemics and lot of major chronic disease conditions. So by this certain kind of examples that will be really beneficial for our PharmD as well as MPharm pharmacy practice students. And in future, whenever it is possible, when you visit India, we will have you in person as well as our sport student chapter will try to have you here. And the clinical pulse which you have covered internationally, definitely in Asian and Indian population, you will. It's now time to go offline also sometimes. So most welcome to you, Dr. Manik, and splendid talk. Nice talk. Thank you.
Thank you very much.
Thank you, Manik, for your wonderful talk.
Thank you, sir.
And sir, we can close the session.
Okay, so formally, thank you, Dr. Manik, for joining us and taking really time from your busy schedule. I know you are in abroad and it might be night time, I think, preferably very morning, or it might be 3 a.m. in the morning. Am I right? What time
No,
is it?
it's 4:48, 10:42, so it's morning.
Yeah. So, okay. So it's morning. So splendid energy you have broadcasted amongst our the clinical buddies, and definitely in future we will have you in person also. Thank you so much for joining, Dr. Sir.
No problem. Thank you very much.